Hello and welcome to another episode of Rings a Bell podcast. I'm your host, Kim Callio, and I don't remember a whole lot from pharmacy school. I do a lot more business and life admin these days than dispensing, and I really need a refresher. So, instead of going and learning about it myself and doing my homework like I should, I just invite on an expert guest who can quiz me and then roast me on what I don't remember. I get to learn, and you get to learn by listening. So, if you want easy to digest clinical updates delivered straight to your ears, you're in the right place. And if you want the episodes to be delivered straight to your phone without you even having to go find them, make sure you subscribe on whatever platform you're using to listen. Today, we have Dr. Shelita Dattani, a nationally and internationally recognized pharmacy leader, advocate, and speaker on the show. She has over 25 years of experience across community practice, hospital settings, academia, industry, and national associations. And Shelitta is on the board of Hypertension Canada, so she knows the 2025 Hypertension Canada Guidelines inside and out, and that's what she's here to quiz me about. So, buckle up and get ready to listen to a true expert quiz and roast your favorite village idiot, me. Welcome to the show.
Thank you. It's a pleasure to be here.
I'm so happy that you have agreed to do this. As a big hitter in the pharmacy world, you're a good catch.
Well, I'm glad you caught me and I'm ready to roll with you.
Perfect. So, Shelly, tell me a little bit about your pharmacy background. When did you graduate? What was your journey from there to here?
Wow. Well, I'm going to keep a bit of mystique about the year of graduation, but let's just say it was when Friends was airing. Sometime during that era, I graduated from pharmacy school and then PharmD school. So, Kim, I went to school in the States, did all of that. I thought I was going to be a hospital pharmacist and an academic my whole career. Didn't want to live in and work in my dad's pharmacy. So I worked in hospital for about 15 years. I did some teaching, Kim, both in Canada and the US. So I was licensed in both countries until just a few years ago. Yeah. And then I moved back to Canada when I was pregnant with my first child and continued to work in hospital for a number of years in various sort of leadership roles. And then I have always had the advocacy bug. Like I always sort of worked on different committees with the Hospital Pharmacy Association, did some work with them as a volunteer, and then joined the Canadian Pharmacists Association for 5 years and led their professional practice and loved that experience advocating for my profession. And I think my dad thought it was neater that I was advocating for community pharmacy predominantly rather than sort of taking over his store. And then I worked for another national advocacy organization for about 4 years. Now I'm kind of in an interesting chapter. I'm doing a little bit of consulting, a little bit of teaching. I'm on some boards, and part of why we're here today is I'm really passionate about preventative healthcare. And one of the things that I think is really important in terms of the role pharmacists can play is in hypertension. And I'm on the board of Hypertension Canada. So we're going to talk about blood pressure today.
Perfect. I need a refresher on those updated guidelines. So I'm really glad that you are here and I don't have to go read them myself. I think this is going to be great. I did not realize that you had your start in hospital pharmacy or that you had a PharmD. So really great to get that from you off the hop. I'm ready for the quiz. Are you ready?
I am ready. Absolutely. Okay, well, I'm going to start off. I always like to start off discussions like this by talking about what the problem is, Kim. So let's ask you. So you are from BC, and you probably have a sense of this in BC, but how many or what proportion of Canadians do you think do not have a primary care provider? So I'll just qualify and say by primary care provider, I mean physician, nurse practitioner, assessed to somebody who is their designated primary care provider. Any guess as to how many or what proportion?
Woof. I want to say it's high. 30%?
Well, it's close to that in some areas. It's more like 20. And again, it depends on the province. So in some provinces, it is approaching 30%. So you're not wrong. But on average, it's about 1 in 5 Canadians. So about 20%.
Okay.
Yeah. And 1 in 3, though, So that's like over 33% of my math is mathing in rural areas. So like in remote areas of BC
I
or
think that's
rural
where I
parts of
got,
New Brunswick, right?
yeah,
Yeah.
because I'm in the
Yeah.
Kootenays.
Yeah. Which I don't even know where that is, but that sounds
I'm
rural.
in a rural area. Yeah.
So you are probably living that 30% or potentially even higher. That's a Canadian average. There are parts of the Maritimes where it approaches, 40%, I know, but we have some challenges. So that is one of the challenges we face in this country right now. And then even if you have a family doctor, and I can relate to this, and I don't know if you can, it is really hard to get an appointment. In a few days. You might be waiting weeks. And we know that people sometimes have to go to walk-ins or they visit their pharmacist or whatever. And we know that the data shows that a lot of the visits that actually end up in the emergency room could have been managed in primary care. And by the way, you and I are primary care providers too, right? We're pharmacists. So 1 in 7 emerge visits could be managed in primary care. And people with elevated hypertension who don't get it treated end up in emerge. Do you remember in school you learned about hypertensive urgencies and hypertensive emergencies? Like
Mm-hmm.
your first visit could be a stroke or kidney failure
Right.
or a heart attack. And not to scare people, but also, yes, to scare people, that hypertension is pretty silent. And if you're not getting it managed and optimized, the impact might not be felt the first year or even the second year, but it will be felt. And we don't want to wait until somebody gets severe disease or until they get that heart attack, because we can prevent, and we'll talk about this more over the next few minutes, we can prevent blood pressure. So you got that first one right, Kim. That's really good. Do you have a sense of what, and this is kind of a bit about the problem too, because I always like to sort of focus on the enormity of the challenge that we're facing and why we're talking about hypertension as pharmacists. But do you have a sense of how many Canadians, or again, what proportion of Canadians actually have high blood pressure?
So about 20% of Canadians don't have a primary care provider.
Mm-hmm.
Blood pressure problems, that's got to be higher. 40%?
Yeah, again, the law of averages is working for you, Kim. So if you think about people who have high blood pressure on the whole, it's about 23 to 25%. However, if you are also overweight or obese. By definitions of obesity, 80% of people who are overweight or obese also have high blood pressure. If you also have high cholesterol, and how many people do you know that walk into your pharmacy, Kim, or your mom's pharmacy that have high cholesterol? A lot, right? Over half of those will also have high blood pressure. So, when you have comorbid conditions or those kissing cousin conditions, those proportions go way up. So 52%, 27% of people who have diabetes, also very common, type 2, right? Also have high blood pressure. Um, and 9% of those without any comorbidities, okay, also have high blood pressure. So the average is 23%. But remember, most of the people that we see in the pharmacies and the people that we're treating and helping usually have one of those comorbid conditions. Very common to have high cholesterol, very common to have diabetes, even being overweight or being obese.
Mm-hmm.
What's scary is that if you don't have a comorbidity, so your lipids aren't being checked, or you're not identified as a person with diabetes, hypertension is silent, so it's 3 times more likely to just go unnoticed, untreated.
Mm-hmm.
And that's what scares me, because that means that less than 50% of people out there, and I'll show you this, or we'll talk about this if we get a chance, actually have their blood pressure treated, but then controlled and optimized. So it's not
Right.
just about treating, it's about optimizing, escalating doses until blood pressure is optimized, until the medication therapy, which is basically mostly what we treat high blood pressure with, is optimized. It is the most common modifiable risk factor for cardiovascular disease. Just let that sink in, right? Like it's the most
Mm.
common thing we can do. It's modifiable, it's changeable. We can stop those strokes and heart attacks, but we're not. And we'll talk a little bit about that. But I really wanted sort of you to understand, and everybody to understand, why I want to come here and talk about it, why we're really pushing the guidelines for primary care and making sure people are aware that they're already a year old, actually. They're not that new, but they're still sort of new and they're current.
I know. And I'm just getting to it now.
Well, a lot, and you're not alone. So I think you know that I just did a little bit of a roadshow and went to a couple of different conferences and talked about the guidelines. People were aware of them, but that pretty much stopped there for a lot of people.
Yeah,
I mean, it's just there's so much that we have to learn and understand and absorb as primary care providers, pharmacists, family doctors, nurse practitioners. It's hard, but this is one where we really need people to understand their role and what they can do.
absolutely.
So, where do you think we are in Canada compared to around the globe? Like, I gave you a sense that we're not controlling, maybe I gave you a sense that we're not controlling hypertension as well as we should from a population health perspective, because this is a public health issue. Like, it's not just an individual issue, it's a population health issue. Do you have a sense of where we sit compared to other countries around the globe? Or do you want to take a guess?
I'm I'm going to say we're better than the States, but we're worse than Europe.
Yeah, that's again, you're playing your law of averages really well. And that's probably there's some truth in that. I think, and I'll just give you a sense of where we are globally. So I won't break it down in countries. That'll be another podcast where we talk about
Okay,
all of the
got
different
it.
countries and why. But our rate globally is in terms of how we control hypertension between, let's say, people from about the ages of 30 to 80 is under 50%. It's probably closer to 40, maybe even a little bit less. Um, our prevalence of hypertension globally is around 30%, and we come in a bit lower. So we're doing well on prevalence. We're not
Oh,
like,
okay.
we're relatively healthy compared to the rest of the globe. We're a little bit lower in terms of the prevalence of hypertension, but the prevalence doesn't matter as much as what we do about it. So in terms of what we do about it, we know that about 80% of people are diagnosed. So of the 6 and change million Canadians that have hypertension, 80% are diagnosed. 22% are those silent people that you said don't even know that they have it. They haven't been diagnosed. And of those that have been diagnosed, only 3/4 are being treated. So that's good. Like 75% are being treated, but that's not perfect. If you know you have it, why aren't you being treated, right? And of
Mm-hmm.
those who are being treated, then the ones who are being treated, about 61% are controlled. And to me, that's not acceptable. Like their blood pressure isn't targeted. So maybe what's happening, and I'm just speculating here, is they're going to their doctor's office and they're getting started, but they're not optimized. Maybe they're having that blood pressure visit every 6 months. Maybe they're not. They don't feel
Mm-hmm.
symptoms. They're just going on with their lives, and their blood pressure is still not where it should be. And that's something that we can do something about. So each step in there that I just mentioned to you loses some people. The gap
Mm-hmm.
between being treated but being optimized and controlled and having their blood pressure at the range where we want it is actually where I think that we can help. We know that people are
Mm-hmm.
on medication. We know there's still not a goal, or there are ways we can know that. And we can potentially prevent all of those scary things that I talked about at the beginning.
Absolutely. And being uncontrolled with your hypertension or not optimized isn't necessarily going to land you in the hospital right away. But if it gets bad enough, it will. And then it's a big crisis. And now we're dealing with
Yeah.
all the issues post heart
Yeah,
attack
for
or stroke or
sure.
whatever. But,
Yeah.
having pain that's not optimally managed, that
Yeah.
that might be dealt with a bit faster because a person's going to notice.
Good point. Very good point. And in this case, your blood pressure could be, maybe it's 150, maybe you're creeping up to 160. Like I've had patients tell me, I know I get a headache when my blood pressure goes above 170 or 180. But then I've had people say would have had no idea. And then I've seen people just get chest pain or have strokes. Or when I worked in the hospital and saw who was coming through emerge, a lot of those people were silently having this escalation in blood pressure and didn't know. And you're right, they can go on for a long period of time or maybe not. It just depends on the scenario. But I think that the message there is that if we're screening and monitoring at appropriate intervals, they don't have to be there in the first place, right? So
Mm-hmm.
okay, so that's some of the scary stuff in terms of, what the reality is. I like to scare people into submission and, have us understand that this is a big problem that we can control.
Listen
I
up,
think
folks.
yeah, that listen up, folks. Exactly. And I think part of the reasons for control not being great, we used to be number one in the world, like in the late 90s, and I think even in the 2000s. Don't quote me. Um, my friend and colleague Ross Suyuki is a big hypertension researcher that I'm sure you've heard of. Ross, he used to say, like, from a legacy perspective, we used to be number one or close to number one in the world in terms of our hypertension and our blood pressure control. We're not there anymore. Like I just showed you that data.
Wow.
And we'd love to get back there. And that's part of the reason I joined the board at Hypertension Canada. I was like, this is such a preventable disease, and it's so easy to manage in terms of
Mm-hmm.
uncomplicated hypertension, which is what most people have. And family docs are busy, just like we are. Nurse practitioners are
Mm-hmm.
busy. Nephrologists manage challenging hypertension. They don't have time to manage the simple, straightforward hypertension. So there's a place where we can add and integrate our knowledge into care. But
Mm-hmm.
part of
And
the
it's a double
reason,
whammy.
it's a double whammy.
Because if you actually manage the uncomplicated stuff, you're not going to get the complicated stuff. You're not going to get the renal disease and the post heart attack and the post stroke hypertension.
Yeah. Well, they're complicated in two senses. One, in that, like, you won't get the end organ damage. You're correct.
Mm-hmm.
But some people actually have resistant hypertension where their arterioles
Okay,
are just
gotcha.
so resistant that you end up having to manage with 3 or 4 drugs. And there's actually studies out there. There's a great paper out of the University of Waterloo that some of the pharmacy folks did that said they were actually able to even manage people with resistant hypertension and get them, because we're medication therapy experts, get them on 3 different drugs, 3 different classes, and we'll talk about what those look like in a couple of minutes. But sometimes those patients do need to be referred to nephrologists who manage the more complex disease, whether it's due to aldosterone challenges or whatever it is. But in terms of straightforward hypertension management, you're right, Kim, and keeping people out of the hospital. Remember, I said it's the most modifiable risk factor. There's a lot that we can do
Mm-hmm.
for sure. So you're right. So I think part of the reason that the people who wrote the guidelines, the new guidelines, felt that we weren't controlling hypertension as well. One of the reasons is the old guidelines were super complicated. The recommendations were complicated. There were different targets for different people. There were 7 different drugs that you could choose from as first line. It was like, just tell me what to do. I'm busy. I have a
Yes.
busy practice. I'm a busy pharmacist. I can't remember all of this. Keep it simple, stupid. Like, just
Yeah.
give me something simple. So that's essentially what the new guidelines are like. They are focused, just like they say, on primary care. And they were written, by the way, I wasn't on a guidelines committee, but I'm on the knowledge mobilization committee at Hypertension Canada. So I'm trying to mobilize the knowledge, just like we are right now, of what
Mm-hmm.
these guidelines involve. But there were primary care doctors, physicians, nurse practitioners, pharmacists, even patients involved in this guideline. So there's a public forum as well to give people the agency of knowing that this silent
Mm-hmm.
disease needs your attention,
Oh,
and you need to
fabulous.
help. Yeah, yeah. So giving them the agency, and like I said to you, most of high blood pressure is managed in primary care, over 90%. So that 10% of complicated resistant hypertension will go to the specialists, maybe a cardiologist, maybe a nephrologist, but most hypertension is managed in primary care. So that critical mass, making sure that we keep it simple for the people who are treating it, is really, really important. We know that control rates are declining. I just talked to you about that. And we know that the more complex the guidelines, the less likely they are to be taken up in terms of how we want people to treat hypertension. So that's a little bit about the guidelines and why they started that way. Let's get into, if you want to, the actual guidelines now. So let me turn it back to you because I've been doing a lot of talking. Um, but let's see if you know this. So, one of the new big things in the 2025 hypertension guidelines is around, there's a lot of time spent on measurement and diagnosis. So, do you know, Kim, what the type of how we actually measure blood pressure? What is recommended now in terms of what instrument we use to measure blood pressure? There's giving you a bit of a trick there to see if you can figure
Mm.
it out. You want to guess? It's a
Well, I
hard
mean,
one, but
when I graduated, we were taught to use a stethoscope.
Mm-hmm.
to measure.
Mm-hmm.
I don't know. Maybe there's a change. Are we
Mm-hmm.
using the automatic blood pressure cuffs now?
She's so good with this. She's like reading my eye
I'm trying to
contact
read the
here.
room.
And yeah, you're reading the room. And this is a fun one, by the way. Your daughter's next birthday party, you can say sphygmomanometer 10 times fast and have people getting dizzy, or an auscultatory method. These are all the medical terms for exactly what you said, the stethoscope. And my I don't want to out my doctor on YouTube. I think she's changing over to an automated device, but lots of care providers are still using the stethoscope. I'm going to pause for that, and we're going to go through that in a second. There are reasons, actually, no, I'm going to go through it now. There are
Yeah,
reasons
get it.
why we don't use stethoscopes anymore. So you're right. The recommendation now is a validated automated device. And Hypertension
Okay.
Canada, plug for Hypertension Canada, we validate and recommend, and we give different ratings to different devices and endorse them based on how reliable they are. But we now recommend only validated automated devices, and that's what the guidelines recommend as well. Do you know why? Like, why do you think we don't use stethoscopes anymore, and
Just
why we're
less
going against
user
this?
error, I would imagine.
100%. Yeah. So there's a high observer bias. Like if you've ever listened, sat there in the doctor's office or wherever and watched somebody take your blood pressure, or you have done it yourself, maybe back in, I don't know, lab and
Oh,
pharmacy
yeah.
school,
That was
right?
the
Do you
last time
remember?
for sure.
Yeah. Yeah. We tend to round up or down.
Mm-hmm.
We people get stressed out just watching us take blood pressure. We get to a number that we want. There is a huge amount of observer bias. So it is not something that we do. Again, we don't rely on a stethoscope. We don't rely on our ears. There's lots of error. So
Mm-hmm.
we are definitely moving to automated devices. And that's a lot more straightforward. If you've used them, if you have one at home, if you've used one in your pharmacy, in your mom's pharmacy, and that comes with very strong recommendations to use automated. The other thing that comes with strong recommendations is to do an out of office blood pressure assessment to confirm high blood
Mm-hmm.
pressure. And do you know why that might be, Kim?
The old white coat syndrome.
The old white coat syndrome. Exactly. So about
I'm wearing the
how
black coat
many
today, so we
you're wearing a
won't have
black
any of that.
coat. No, and you're not intimidating at all. You probably lower blood pressure because you make people laugh so much. So you're the care provider that we need you more in the pharmacy checking blood pressures, Kim. So,
Okay.
Kim, since you're so good at the proportions, what percentage of people, and it's a range of people, do you think out there have white coat or elevated office blood pressure? So, just for our listener, our millions of YouTube followers that you have on your channel, white coat hypertension is people who just get stressed out when they see, and often we're not wearing white coats anymore, but with they're in an office, a
Mm-hmm.
doctor's office, maybe an NP's office, maybe emergency room, or maybe a pharmacy. They're maybe sitting there
Mm-hmm.
at the kiosk. That's also white coat. Okay.
True.
So, what percentage of people have white coat? And it's a range. You could say up to.
Up
Yeah. We're talking
to
proportions.
30%.
You are good at this
Man,
game.
I
You are ringing the bell in rings a bell. 15 to 30%, up to 30% of people have an elevated office blood pressure. You could be wearing a black coat, a purple coat, you could have 3 ears, but just the fact that somebody is sitting in an environment where they feel that they are being judged or watched or whatever the behavioral response is, your blood pressure, it's very common for people's blood pressure to be
mm-hmm.
elevated when they are not at home, when they're in an area where they're being assessed. There's also masked hypertension. There's also up to 15% of people who actually have a normal blood pressure in the office, but elevated out. So, we have to watch for them too, because they might appear controlled, but they're actually
Mm-hmm.
not. This is another reason we check out of office. We have to do routine. We have to look for patterns in high blood pressure. And of course, the gold standard of checking blood pressure. Do you know what that is? Not a sphygmomanometer. We've talked about that now. Not even an in-office blood pressure device or a home device. So what's the gold standard? If we all had the gold standard, do you know?
I don't know.
It's actually an ambulatory blood pressure monitor. So you could actually have somebody walk around
Oh.
with 24-hour, like a Holter style ambulatory monitor. Those are sometimes the home health places have them, clinics have them. They're not
Mm-hmm.
easy to get, but they're gold standard. They correlate your 24-hour blood pressure continuous correlates most closely with end organ damage. So sometimes they use them in trials, and if they have people who have really challenging blood pressure, they will have them wear an ambulatory blood pressure monitor for a couple of days. But for the critical masses and the large numbers of people, those just aren't as available. So, and we know the automated devices are pretty accurate. So we really are encouraging people to buy or take on loan or something, an automated device, and take their own blood pressure at home. That's a big change from last time. And I think that's why giving people the agency to say, this is important. Like, this is something you can so easily do now. Like my, exaggeration, but my 3-year-old golden doodle, because I don't have your 3-year-old daughter, could probably do this. It's very, very easy. Couple of things when you're checking your blood pressure. Either at home, so Kim's checking it at home, or Kim's in the pharmacy and checking it, is keep your feet. So here's a couple of fun little trivia questions for you, Kim. You want to tell the person to keep their feet flat on the floor when they are checking their blood pressure. Why would we say that to someone? Why would it matter?
Feet
So no,
flat on the
no,
floor.
So no
You know what?
crossed legs.
Just accurate blood flow, like you're not having any pinches in the venous return.
Very good. So she's using fancy words like venous return to really impress her audience. She's a very good clinician. Just think of it as like a kinked hose. So when you cross your legs, exactly right, Kim, you compress the blood vessels in your legs, and that makes the resistance to blood flow greater, and it can increase your blood pressure, even up to 10 millimeters of mercury. So it's really like kinking a hose. When a hose is unkinked, when it's kinked, it's compressed. I did a workshop a couple of weeks ago with 30 pharmacists, and I had them check their blood pressure with legs flat on the floor and legs crossed. And this is just a sample size of 4. I had 4 tables of about 10 pharmacists each. Each table saw a difference in blood pressure. When their legs were crossed, they saw blood pressures go up. Maybe it could have been due to other variables, but it was interesting that we were able to prove that in the moment. So now you're never going to forget, right? Feet flat on the floor, arms supported, back supported. What are some of the other obvious things when you're telling somebody when they're checking their blood pressure at home or they're at the pharmacy with you? What are some other things you're going to want to think about? Just name anything that comes to mind, Kim.
Don't do it immediately after a workout. Don't do it after slamming a cup of coffee.
No caffeine. Good one.
No
Yeah.
caffeine.
Even if you're sipping.
Yeah.
Not slamming. Even if you're sipping.
Maybe don't take it immediately after taking your salbutamol.
Great one. Great one. Yeah. For those people who are on medications that increase their heart rate, absolutely. Exercise, same thing. If you've just come from a workout, often people are running into the pharmacy and checking their blood pressure really quickly because they see the machine. Not the best time to do it either. So you want to be relaxed. You want to be resting between readings, and people don't understand what that means either. Like the guidelines say, rest 1 to 5 minutes between readings because you're supposed to do 3 readings.
Right.
And they hit slam, 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 slam. Check one, check one, check one. So it's a good thing to say. Do you remember the 1 Mississippi, 2 Mississippi thing?
Yes,
Have them
I
do
do
some
remember.
Mississippis, or count to 10 or count to 60 slowly. So those are the types of things that you want to think about when you're talking to people about measuring blood pressure. And I spend so much time on this, even as pharmacists, because it's really important and it's really highlighted. We spend a lot of time in these guidelines. Your cuff should also be placed where? Do you know? The blood pressure cuff when they're wrapping it around?
Placed on your left arm.
Doesn't matter.
Doesn't matter?
What arm?
Okay.
No.
2 finger widths above the elbow crease?
That's pretty
Is
close,
that
about 3 centimeters.
3
So 3
centimeters?
centimeters above the crease of the elbow, which is probably close to 2 finger widths. So I think that's a fair assessment. I don't know. It depends on how big your fingers are, I guess.
Yeah.
But you're trying to find that brachial artery, right? Remember the brachial artery that we talked about in school, and you're trying to line the marker. There's actually a marker on the cuffs that are on the home devices up with your brachial artery, so that's where you'd actually feel, like if you're actually feeling your pulse there, right, with 2 fingers, that's where it would inflate. That's where the bladder of the cuff would inflate. So you want that bladder kind of centered over that artery Or you'll probably get an error message anyway. The cuffs are pretty sophisticated now. There you go. So you'll get an
Be a
error
flex.
message.
Right.
What about if somebody says to you, "Do I need to take my shirt off?" Doing, they're not gonna, they're not saying that inappropriately, but they just, "Do I need to take my," that didn't come out right. "Do I need to take my jacket off, or do I need to roll up my arms like when I'm getting vaccinated? Like, do I have to come in with short sleeves?" Because we're vaccinating a lot of people right now, right? So we're often telling them, it's better if you have a short sleeve and it's easier to access your deltoid. But what about blood pressure? What do you think?
We do not need to see your abdomen, but we also don't need you in a winter coat or a sweater. So one
Okay.
layer of clothing would be
Yeah,
my
I think
guess.
that's fair. And in fact, you could actually take a blood pressure over a thin shirt. It doesn't make a huge difference. I think you just kind of use your judgment. If it's a really thick fleece, or, if it's a rolled up sleeve that's starting to sort of almost create a tourniquet, that's going to elevate your
Mm-hmm.
reading. So that doesn't make any sense. So just use your judgment like a
Yeah.
pharmacist, like, okay, this is a really thin, they just have a thin, it's the weather out right now. Like, I've got short sleeves on, but I could walk outside with like a thin hoodie. And you could
Yeah.
probably take my blood pressure over that thin hoodie instead of having maybe the sleeve of that hoodie rolled up really tight. I'd
Yeah.
rather I'd rather do it the first way so that it's not feeling like
Mm-hmm.
a tourniquet. Okay, so I think those are the key points about checking blood pressure and what you would tell people when they're checking their own blood pressure. Just to recap: feet flat on the floor, no caffeine, exercise, tobacco for 30 minutes roughly beforehand. You're taking 3 readings, but you want to try your best to rest or to count in your head, meditate, whatever you need to do, count sheep between those 3 readings. People react when they see that first reading high, they panic and they just want to take that second and a third. But as much as you can get people to relax, the better.
I usually
Um,
tell people to go get a home and garden magazine and sit down with it.
Love it.
Flowers will make you very chilled out. And then we have
Love it.
upsales on our magazines.
Brilliant. That is great. Yes, kill 2 birds with 1 stone. That's amazing. So, do you have what do you think about the blood pressure kiosks in pharmacies? I don't know if you have one in your. It's okay to keep saying your mom's pharmacy, your family pharmacy. Do you have a blood pressure blood pressure machine there, a blood
We do
pressure device,
not.
a kiosk? Okay, think about it. Like, how many of those do you see? Do you
A
still see
lot.
those?
Mm-hmm.
Yeah, I'm actually seeing less. And maybe this is just my observer experience. So I'm doing some locums, as you know, the last few months I've been doing a little bit more just to sort of see what's happening on the front line. I work 2 or 3 times a month, and I'm not seeing them as much. And mind you, I'm working more in the independent stores, but it's
Mm-hmm.
actually, they are what people are telling me a couple things. So pharmacy owners and pharmacists are telling me they're expensive. They're expensive to keep recalibrating. They take a bunch of square footage out of the pharmacy. Um, but I think the more important thing is that most of them aren't validated. So there's only 2. Remember, I talked about
Okay.
Hypertension Canada and we endorse blood pressure devices. There's only 2 um, that are currently on our recommended devices list. So many of the kiosks that you see in pharmacies, you might want to check if you're a person and you're listening to this to see when it was validated, or if you're a pharmacist, you might want to check with your manager or the owner. Do you know when this was last validated? Maybe it's time for an upgrade. Maybe we can even switch to using just the blood pressure automated devices and keeping a couple of them in the counseling room. So this is what I'm starting to see more and more,
Mm-hmm.
is people are keeping them in the counseling room. When I've been working, I've just been telling people, go in there. I'm going to show you how to do this. I'll be right outside. I'm going to have you check your own blood pressure. And they
Mm-hmm.
relax immediately, versus me, because I'm pretty quirky and pretty chatty and I'm probably raised their blood pressure. So I don't want to be that variable and contributing to their
Mm-hmm.
white coat hypertension. But sometimes when people are in the privacy of their own, uh, either their own home or in the pharmacy, by the way, remember, they still would have to validate an at home blood pressure to be diagnosed. But if you're screening someone in your pharmacy and they haven't been diagnosed yet, or they just want to check their blood pressure and they're on
Mm-hmm.
treatment, and you have blood pressure monitors, you can have them go into the counseling room and check their blood pressure that way. And I'm finding that's becoming more common now.
And a lot easier to have, to be able to say
Yeah.
and confirm you got to stay
Yeah.
there. if they're leaving with 3 readings after 5 minutes, they didn't do it right.
100%. Yeah, 100%. Walk me through how you did it. Yeah. So I actually think that's a really neat approach. And I'm seeing anecdotally a lot more people doing that. And there's lots and lots of automated devices that are portable that have been validated by Hypertension Canada, that then many pharmacies then sell them, or they have loaner programs or whatever. Hypertension Canada has been doing some advocacy to get more access to those. But certainly, I would recommend that everybody consider having one of these at home. And if
Absolutely.
you're at the pharmacy, you can go and they have one for you to just check while you're there. Go check, and then you can chat with your pharmacist about it. Even if you're on
Yeah.
medication, that's the biggest. Remember, that's the biggest area where we can make a difference. It's not diagnosing necessarily, but optimizing. Okay, maybe it's time for that amlodipine dose to go up a little bit because you're
Mhm.
just at, the starting dose.
And now I can quickly send a fax off to your doctor and try to sort this out, or I can
Yeah.
use my expanded scope to
So
adapt
you're in
or
BC. Here's another, I wasn't going to ask this, but you fell into this quiz.
ah,
So
damn
in
it.
BC, I know, in BC, what could you do? So let's say that was you, Kim, and you had a person who was on, uh, pick a dose, I don't know, starting dose of amlodipine. I
Yeah,
don't
they
know,
were on amlodipine 5.
5 milligrams. Okay. So they come out, well, let's just go through this like we were going through a case. They come out, they have 3 elevated blood pressure readings. What are you going to do next? Are you going to increase
Uh,
their dose right away? Well, they already have high blood pressure.
yeah. I think that I would probably look. Is that the only thing they're on?
Yeah,
Okay,
let's
so
say
they're
that. Let's
on
keep it simple.
amlodipine.
Yeah,
And they're tolerating it well and they don't have any edema or anything like that.
yeah,
So yeah, I could optimize that, go to 10
yeah.
milligrams, see
Yeah,
how
if
it
they weren't
goes.
on anything, right? If they weren't on anything and they were just checking their blood pressure at your store, they need to confirm that at home. Remember, we said that we
Mm-hmm.
need to have uh, a confirmatory blood pressure reading at home. But in this case, the patient already has high blood pressure, and yeah, if they're having consistent readings, you want to be conservative. You can have them come back the next day. But if they have 3 consistent readings that are elevated, you actually could use your scope in BC, and you can adapt. You can increase that dose. And what you're even luckier with in BC is you're remunerated for that.
Yes, which
There's
is great.
actually a fee that you can charge, which is fantastic because you are getting valued for your time for that
Uh-huh.
assessment. And you can do, I think, a few of those a year. So when I was out in BC last week, I was talking to the BC pharmacist about that and said, we do have scope to optimize. Let's leverage that scope if we can, or build it into our workflow and bill for that, because you are caring for that patient and optimizing their therapy. So absolutely. Okay. So hopefully we've convinced you that, assessing blood pressure, both for initiating, diagnosing, validating, and optimizing therapy is really, really important. What should we talk about next? So did we talk about the number, the magic number? What is the magic number now? I don't think we've actually gotten there
No,
yet.
I
So
don't know.
what is the number? There's one number that you have to remember now. And before, I'll just tell you the before. Okay, before it was confusing. So in 2020, in the
Mm-hmm.
previous guidelines in 2020, it was a blood pressure greater than 140/90, but then it varied by your risk category. So if you have this risk, it might be higher, it might be this or this or this. And that's what got people
Yeah.
all in a tizzy. And they were like,
And if you
I
had
can't remember.
diabetes, it was
Right,
it was
right,
different.
right.
I think it's 130 over 90 now.
Close, very close, but no
130 over
cigar.
80?
Yeah. Second guess, you got it. Yes, 130/80. It's one definition, one number for all adults. And that's because of a couple of different reasons. We know that when we get to um, that number, that there's randomized controlled trials that show that there is a benefit of treating at greater than that, that people just wanted simplicity. So they told the guidelines committee, like, we just want this to be simpler. And often in the clinical trials, they actually use 120, right? So 120/80 is like a lot of people, the average Joe that you ask will say a perfect blood pressure is 120/80. Sometimes we check, that's what we use in clinical trials, but that's actually very hard to achieve in practice. So what the guidelines committee said was 130/80 is still going to get you the same good outcomes, and it's just more achievable. it's just more achievable. Like you're
And you're
chasing
less,
this unicorn with 120 over
yeah.
80. It's difficult to get in people that are hypertensive. And you're less, sorry, I interrupted you.
You're less likely to throw someone into low blood pressure accidentally that way. If you're
You
trying to
are
hit,
so smart. Yeah. You are
ooh,
so smart. Woohoo. And let's hold that thought because we're actually going to talk about that in just a minute. What are the risks of throwing somebody into low blood pressure? But before we
falls.
go
Sorry.
there, yeah, there's a few. Yeah, before we go there, it's a couple of things to remember. A lot of people have said, well, we have a validated device. So that's now we accept the fact that we don't want the variability. I don't think anybody's really complaining about letting go of the stethoscopes. Like I think everyone agrees that that's a good thing. But the other thing that often gets asked is, well, we're going to be diagnosing a whole bunch more people now if we're looking at 130 over 80 as being our threshold. And that's true. And the estimate has been that about 9% more people will be diagnosed with hypertension in Canada. But that's not necessarily a bad thing. We want to identify those people, right?
Hmm.
And not all of them are going to be on drug therapy. We're going to talk about lifestyle in a minute. So that's important to know as well. And the single number is just much easier to remember in terms of, what a standard blood pressure will give you and then what a standard blood pressure at home will give you and your risk. So you talked about falls and other harms. So we also want to think about, is there a downside? Right, Kim, is there a downside to treating a little bit more aggressively to 130 over 80 over less? And we actually have studies that say the benefits of treating to 130 over 80 or less are really good. There's much less stroke. There's much less heart disease. There's much less heart failure. There's much less cardiovascular mortality, or in plain language, because we know all the millions of lay people that are following your channel,
Yes.
uh, less risk of dying from a heart-related condition if you target
Hmm.
to this number. The interesting part also, though, is that the number needed to harm. Do you remember what number needed to harm is?
Yeah, not great at stats, but it's the amount of people you need to treat before you hit one person who has a problem.
Brilliant. You are brilliant. Exactly right. And that is something that's important. And I'm going to give you just a perspective of that. So the number needed to harm for falls. So I always worry about falls, like people having low blood pressure. And I have parents in their 80s. I have patients in their
Hmm.
80s, and I worry about fall risk because we know that once someone falls and they're an octogenarian, especially, that's not a good thing. The risk of
Hmm.
injurious falls, you have to treat 2,941 patients before you actually got a fall.
Oh,
So the number needed to
wow.
harm is 2,941. That just gives you some perspective, like injurious falls. So regular falls, maybe
Yes.
not, but falls that actually caused injury. Give you another example. People to have actual acute kidney injury, you'd have to treat 1,657 patients. So the number needed to harm is 1,657 before you got one acute kidney injury.
Wow.
Syncope or low blood pressure fainting, 1,700. So you'd have to treat 1,700 patients before you get to that. So the benefits of treating aggressively are huge. The harms are low. The
And
harms are
so,
rare.
so
Yeah,
when you say the benefits of treating aggressively in these studies, is that the benefits of treating to this target no matter how you get there? Or is that with this new guideline version of the treatment where you're using three different
great
drugs?
point. It's no matter how you get there, but we'll talk
Okay.
now about why some things are recommended more than others. It is no matter how you get there, but with a caveat that there
Okay.
are more predictable ways of getting to a good high blood pressure faster now. And that's why we recommend the combination therapy. And that's a perfect
Okay.
segue into that. She's keeping me on my toes. This is like rings a bell, Kim Callio. Awesome. Okay, so I've convinced you that treating to a target of less than 130 millimeters of mercury, and we worry, by the way, more about the systolic, the top number. The bottom number,
Hmm.
we don't worry about that as much anymore. Lower is generally better for the top number, and we don't worry as much about the bottom number. So you can tell people that as well.
Okay.
Um,
Excellent.
in terms of the if so the target is 130 over 80, as I said before. We generally are going to be recommending lifestyle first, and we'll talk about the lifestyle, unless the person is also high risk. If they're also high risk
Mm.
and they have that sort of elevated blood pressure over 130, like, so for instance, if their blood pressure is 130 and they're also high risk, we're going to treat them. If their blood pressure is 130 or greater and they're not high risk, we're going to try lifestyle first. So when I say treat, I mean treat with medication. Okay.
Got it. Okay.
One of the things to remember, though, is high cardiovascular risk is, again, if you remember what we talked about before, very common in people that we see. So,
Mhm.
what are some of the things that you would consider high cardiovascular risk?
Obesity,
Okay.
smoking,
Okay.
uh, autoimmune disorders,
Okay.
um, high cholesterol.
Yeah. So maybe even think a little bit more simply. So to be high cardiovascular risk, first of all, if you already have cardiovascular disease, so if you've already had a heart attack, if you've already had stroke, if you already have angina, if you already have heart failure, if you've had a TIA, you're automatically high risk. Not an insignificant number of people that we see, right? If you have
Mhm.
diabetes, it's like I always tell people, if you have diabetes, it is like you've already had a heart attack. Like that's what it's like.
Right.
You are that high risk. If you've got kidney disease, that also puts you at high risk if you
Mm.
have chronic kidney disease. And you remember the good old Framingham risk score?
Oh,
Do you remember the
yeah.
Framingham? Yeah, so you can calculate a
Bringing that
Framingham.
back.
And by the way, any pharmacist can do that. It takes 2 minutes to do a Framingham in your office. We're not going to go through it now, but
Mhm.
happy to do that. If you invite me back, we can talk about Framinghams.
Well,
Um,
girl, you're invited back.
if your 10-year Framingham is greater than 20%, automatically high risk. If you are over the age of 75, automatically high risk. So if that
All
blood pressure
right.
is hovering around that 130 range, but you also have one of these risk factors that I just maintained, we don't waste our we go right to drugs and lifestyle. We don't just say, let's try a few months of lifestyle. Okay. How are we doing for time? You doing okay?
I mean, I think we're doing fabulously. I have had some people who are much more verbose than you. So
Okay.
I think we're good.
Okay. 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 So now we talked about, or you touched on the drugs, and we're going to talk about the drugs in a second in detail. But I will tell you before we get into lifestyle that if you go on drug therapy, we now recommend combination right away. And it sounds like you already knew that because you were sort of hinting at that. Whereas before when
Yeah.
I went to school in the dark ages, it was like, okay, start with a diuretic and low dose and then step up and then add another class and add another class. And no one ever got there. And
I do
people, yeah, what's
I
that?
do love that at the beginning. I'm like, when did you graduate? I will never tell you. It's a secret. I'll take it to my grave. And then when
And
I
the dark
graduated in the
ages.
dark ages,
Well, I said it was like sometime when Friends was on. So that gives you a span of like 10 years or something. Somewhere in that span, I graduated. Sometime before, sometime before 2002, I think it was, because Friends' last episode I was watching, sidebar, is it okay?
yeah,
Last
this is
episode
what
of
I live
Friends I
for.
was watching, she's going to kill me because she's right outside. When I went into labor with my daughter, it was when Jennifer Aniston was having her baby on Friends. And it was like the second to last episode. I was watching it and then my water broke and I went into labor. And you know what? My daughter is a Friends addict. She has watched every episode at least 9 to 10 times. She can quote exactly what Joey said when. Anyways, I digress.
That's so cute.
Friends is the frame of reference for this. I'm going to make her watch this podcast now when it's on. Okay, so we're going to talk about combination therapy and why we started. But before we do that, I want to talk a little bit about lifestyle. Okay, so if we start people, whether we start them on drugs right away or whether we say we're going to try 3 to 6 months of lifestyle interventions, let's talk about what lifestyle interventions mean. So, what are the typical things that you would counsel your patient on, Kim, when you're saying, okay, my doctor told me, a little bit, but also told me to talk to you about how I can incorporate good lifestyle interventions for the next 3 months until I see him again to validate whether I have to go on drug therapy? What are some of the things that you might touch on?
Yeah, I'd be talking diet probably first. Diet
Hmm.
and exercise would be my first two, specifically the Mediterranean diet for hypertension. I don't know if DASH is still a thing or
Hmm.
not, but it was when I graduated.
Yeah.
I have some specific experience in therapeutic nutrition with
Oh,
low
yeah, you
carb
do.
diets
Right.
and helping
Functional
to
medicine, right?
functional medicine, but most of my experience in therapeutic nutrition was with the actual IPTN out of Vancouver and working within a study where pharmacists were helping to monitor and set up deprescribing plans in type 2 diabetes patients and type 1. But
Okay.
yeah, the idea there in terms of hypertension being that, your sugars are actually contributing to the high blood pressure as well. So if you go low carb, then often we actually have to change the doses of hypertensive meds so that you don't go low.
Yeah. No, those are all good points. And the dash is still a good starting point. But I think to make things simple for people, there's a few key pillars that the guidelines committee kind of zoned in on for this new iteration of the guidelines. One is the one that we've always talked about, which is sodium restriction, right? So sodium
Mm-hmm.
restriction less than 2 grams a day. Now, where do we get most of our sodium in our diet? Do we get it
In
from the salt
processed
shaker?
foods.
Mm-hmm.
Yeah.
Right. So we're not, yes, we're counseling around table salt, but let's not spend our time on table salt. Let's spend our time talking about the drive-through or the Uber Eats
Mm-hmm.
or the M&M frozen food, which a lot of older people who aren't cooking anymore go to those types of
Yep.
places. And I think you have M&M in BC because I just asked that question when I was out in Vancouver. Check your sodium in those processed foods. And that's really the biggest culprit. So read the labels. That's really the
Yeah.
biggest thing is to read those labels. There's also a little bit around potassium targeting to greater than 3.5 grams a day via fruits and vegetables. That lowers blood pressure and reduces cardiovascular risk. But we have to keep in mind that when we're going to talk about this in a minute, that lots of the medications have effects on potassium, lots of the blood pressure
Right. Right.
medications,
Right.
right?
Right.
We
Mm-hmm.
now have a lot of people on GLPs too, right? So weight management is important, but we're actually starting to see that the semaglutide and other like agents are actually lowering blood pressure significantly. So they in and of themselves, there's a lot of exciting information that's starting to show that they will actually help and contribute to optimizing blood pressure. So weight management, but maybe even some independent cardiometabolic effects of these agents. I'm not endorsing that these drugs are either is the guidelines committee endorsing that these drugs are part of the therapeutic regimen, but it's just noted that we are
Mm-hmm.
seeing reductions of blood pressure with the GLP agents. Physical activity, right, Kim? And we always tell people to get lots of aerobic activity that will lower blood pressure. It's like adding a medication. If you're doing the right amount of physical activity, about 150 to 300 minutes a week is what we recommend in the guidelines. Alcohol is an interesting one because it has a dose dependent effect above a certain threshold. So at greater than 3 drinks a day, lowering your alcohol intake does lower your blood pressure. But if you've got somebody that's maybe drinking a few drinks a week, maybe just
Right.
on the weekends, there's no value in telling them that they need to stop all of their drinking. It's not actually going to have tremendous effects on their blood pressure. And it's probably not hurting them all that much. There's reasons to, stop alcohol for other reasons, but for blood pressure, not a huge effect at those low amounts. But the more a person
Mm-hmm.
is drinking, and remember, generally you want to double that. If a person's telling you they're drinking a drink a day, that's probably two. So if you're getting a
Right.
sense that a person is drinking over that 2 or 3 drinks a week, definitely counsel them to lower that amount. That will lower their blood pressure. But if there's somebody like me and they're literally only having a glass or two of wine on the weekends while watching the Michael Jackson movie, like I did this weekend, then they're fine. And my blood
Then they're
pressure is
good to
pretty good,
go.
by the way. Yeah, they're good to go. Smoking, obviously, smoking cessation is sort of the sixth one. So I think that's just alcohol. All of these pieces are important for everybody, whether they start on drug
Mm-hmm.
therapy or not. And not to be a pessimist, but most of the time, people at some point are going to have to start on medication, even if they are
Mm-hmm.
vigilant with their lifestyle.
Yeah.
So I think that, again, so just to recap, if a person, when you're going to start drugs, if a person is already at 140 over 90, regardless of their cardiovascular risk, you are going to treat. You're going to start pharmacotherapy. If they're at 130, between 130 and 140, and they have high risk, they're one of those people I told you that has high risk, you're going to also start them on pharmacotherapy. So lifestyle is only for those people that are sort of on that kind of
Mm-hmm.
mid-range and not high risk.
So
Eventually they will all have to, I think most people will have to go on drug therapy. So
there is a special
yeah,
unicorn that wakes up and goes, "Oh, I need to change my whole life." All of a sudden, I'm doing, I'm a
yeah,
fitness influencer. But
yeah,
the majority of
yeah.
people are not that person.
Yeah. And you just don't want people to beat themselves up about it. You want to be realistic with them when you're talking to them. And the other thing that you want to convey is once you go on drugs, it doesn't mean everything else goes out the window. It doesn't mean you can go back and eat all those processed foods again. It doesn't mean you can
Right.
stop exercising. Like we know that, but drugs are not the panacea. They are one
Hmm.
tool in a big toolbox. And lifestyle all the time is still really important, but often it can't do the whole job. And don't beat yourself up about it. It is
Hmm.
hypertension is hereditary to a great degree. Essential, remember we learned, or I did again back in the dark ages, essential hypertension was a term that we used, right? So
Hmm.
very common in families. Although weirdly, I'm still normotensive with two hypertensive parents. So knock on wood, something I'm doing.
Woohoo!
Yeah, it's exciting.
Well,
Yeah.
you've been studying,
Yes, yes,
so
exactly. Exactly.
you know what's up.
Yeah. I tend to run on the low side, so I don't know. Okay, so let's talk about the drugs because we are pharmacists. Let's spend a few minutes talking about the drugs. So, as I mentioned, as I kind of alluded to, Kim, at the beginning, we start with a low dose combination now. The data
Hmm.
has really shown us that if we start with combination therapy, about 70% of people who have high blood pressure will need more than one class of medications. And so it's better to just start from the beginning. People are more adherent, and particularly if they can take a single pill combination, they're more adherent, even if they're taking individual components. Okay, they're more adherent. So the drug that's been mentioned in the guidelines, and part of the reason is just because, well, actually, maybe I'll ask you.
Okay.
Um, do you know the combination drug that has been mentioned in the guidelines as one of
Um,
the combination starters? Or do you know, let's back it up. Let's back up the train for a second. Do you know what classes we want to start with in combination? So what drug classes? So remember before I said in 2020, it was like you could start with this. There was like
hmm
16 choices. I'm exaggerating, but lots of choices and
There
it
was a
got
lot.
people
Yeah.
confused. Now it's a bit simpler.
I think we're going. I did attend Michael Boivin. I don't know if I said that right. His
Boivin, it's Boivin, but he would love
Boivin.
that you said Boivin. It makes him sound
Boivin.
so, yes.
So cultured, which he could
Yes,
be. Haven't
he is
really
just
talked to him.
he's cultured. Cultured boy from Barrie, Ontario. Absolutely. Yes.
So I attended his session, and I think I remember it being a diuretic
Hmm.
plus
What
a
kind of
ACE or ARB,
diuretic? What kind of diuretic? Yeah, and
hydrochlorothiazide.
what's the class? What's that class?
That is called a
You already
thiazide
said it.
diuretic.
Right. Right. Thiazide diuretic. Yep.
She remembers some things.
Mm-hmm.
An ACE or an ARB,
Mm-hmm.
and a calcium channel blocker.
Yeah, so it's an ACE or an ARB. So a drug that works on the renin angiotensin aldosterone system, or RAS. If you want to sound again really clever at a party with a lot of medical people, you just say, I'd like to start a patient on a RAS.
Give him the old razzle dazzle.
Razzle dazzle raz, renin angiotensin aldosterone system, something that works on that system. So it could be an ACE, it could be an ARB, could be spironolactone. We'll get to that in a second. We
Hmm.
don't typically don't start that as first line though. That's later. So ACE or an ARB plus a thiazide, because thiazide works more, it works on a different side of blood pressure. So it lowers blood pressure by a different mechanism. So they have complementary
Hmm.
actions. Or you could use a long acting, as you mentioned, calcium channel blocker. And the one that we typically use is a dihydropyridine calcium channel blocker. And there's one that everybody uses, which is
Nifedipine.
nope. But
Oh, sorry.
nifedipine, no, nifedipine it's in the same class as nifedipine, but you mentioned
Oh,
it before. It was your
amlodipine.
patient. Yeah. Amlodipine. And it's interesting, when I was teaching one of my workshops last week, somebody said that they noticed that when people go to walk in, like those 1 in 5 that don't have a doctor, and they go to walk in for some reason and they take their blood pressure and they start them on something and they don't have continuity of care because they don't actually have a family doctor. The number one drug that they see, and this could be some walk-in clinics do great jobs and they have hard jobs, but they often start people on amlodipine. Do you know why?
I don't. Maybe long
because no
acting?
monitoring, no monitoring. And we'll
Right.
talk about monitoring in a second, but they don't have to monitor potassium. They don't have to monitor their kidney function on this drug.
Right.
And then what we find is they also don't get their blood pressure monitored as often as they should. And they come into the pharmacy, and hopefully if they're getting screened, just like
Mm-hmm.
your patient who came in, remember on 5 milligrams and you increased them to 10 with your power in
Yes.
BC and your scope of practice, that's not an atypical scenario. So
That's
remember
true.
that, that those people, when's the last time you actually had your blood pressure checked to see if your dose needs to be increased? Like, yes, this drug won't affect your potassium and it won't necessarily affect your kidneys, but that doesn't mean it's a one and done and we leave you alone. We
Right.
need to check your blood pressure to make
Yeah.
sure
Who
that you
started
are
you on this?
appropriately controlled.
Yeah.
And it's not necessarily even about blaming somebody. It's about the fact that those are the people that I'd keep even a closer eye on because there's no
Mm-hmm.
other reason. Potassium scares the heck out of me because if you have to monitor a potassium and potassium is high, it causes arrhythmias. It can cause lots of problems. But, if somebody's on a drug and they don't have to get labs done to monitor their side effects, that's great. But they do have to have their blood pressure checked. So,
Right. Right.
just a
Yeah.
little thing to think about there.
More who started you on this in terms of like what is the clue about how much I need to do here versus,
Sure.
how well are you
Sure.
followed?
And don't get me wrong, like there's a lot of people who a lot of just think about how many amlodipines you dispense in your pharmacy. It is a very commonly used drug.
Mm-hmm.
Okay. But so is the ACE and hydrochlorothiazide. So often it's the combination, and the one the guidelines mention is irbesartan and hydrochlorothiazide. And part of the reason for that is it's splittable. You can see it's a splittable pill. It doesn't get into shortage. Drug shortage is very common with blood pressure lowering agents. Chlorthalidone, I don't know if you remember this, but again,
Oh
in
yeah.
the dark ages, when I remember a couple of iterations ago, it was all about chlorthalidone being a better choice than hydrochlorothiazide. But now we know that the data shows that both of those drugs are equivalent, and hydrochlorothiazide is just so much more widely available. Lots of different generics make it.
Mm-hmm.
Chlorthalidone has gone on back order many times when people get stuck. So I think a really other nice thing about these guidelines is the guideline authors were being practical as well as just clinically focused. Like
Right.
let's recommend drugs that are actually available. So it's combination therapy. Start with, a low dose and go to a higher dose. And as I said before, people just do better on combination therapy. So we might as well get them started right away. Most of them are going to be on more than one drugs anyway. At 3 years, at least twice of them are going to be on more than one drug. Their blood pressure control rates are better. And we know that actually their hospitalizations and all cause mortality or all cause death are lower. So that is a really good case for starting combination. Irbesartan hydrochlorothiazide is not the only drug that we can start. There's lots of options, but that was selected as a prototype in the guidelines because it works well. People tolerate it. It has the two complementary drug classes
Mm-hmm.
already in one pill. You can split the tablet
Yeah.
for a low dose start.
And then you don't
Here's
need to
a
worry about a cough. You've already just gotten rid of the Ramapril situation. It's just like, we're not
well,
managing that.
right, but a lot of people don't have cough on ACEs. So here, you walked yourself into two quizzes.
Ugh,
Here's two
damn it.
mini quizzes for you. So one quiz is if a patient is on an ACE and they do have a cough, which is significant. I think it's 30 to 40%. I should look that up to double check, but it's not insignificant, right? We've all seen
Mm-hmm.
people get coughs on ACE inhibitors. Do ARBs cause coughs?
I think they can, but less likely.
Yeah, it's very, very rare. I'm just going to look this up in real time. With the ACE inhibitors. It is much more rare for angiotensin receptor blockers to cause a cough. And I have had people say to me that I've seen a cough on a patient who I've switched from an ACE
Mm-hmm.
to an ARB. What do I do now? ACE inhibitors prevalence of cough. Oh, I was right. It's up to 40%. So it's pretty common with ACE inhibitors. Okay. But with angiotensin receptor blockers, think about their underlying disease. A lot of people who are on these drugs also have an element of heart failure, and heart failure very common. It's the disease itself that causes the cough. So,
Right.
so it's much, much less common with ARBs than it is with ACEs. But you're right. ARB and hydrochlorothiazide, definitely less risk of cough. You're right. And also a bit of a neutralizing effect, hopefully, on the potassium, because the ARBs increase your potassium, remember?
Oh,
And the
yes.
hydrochlorothiazide lowers your potassium, so you could neutralize potentially that effect in
Oh,
that patient.
yeah.
What about using ACEs and ARBs together, Kim? Can we do that?
No.
No. And people still
No.
ask
No,
that
no, no,
question.
no.
I still have doctors that ask me that question. Contraindicated. And we have a trial called the On Target trial. Again, another little show offy thing you can do next time you're talking to a doctor or patient. Well, the On Target trial showed that people who were on ACEs and ARBs actually had an increased risk of hyperkalemia or increased potassium. Both of those drugs increase potassium. So together,
Yeah.
scary.
Yeah,
They
yeah. We
drop
don't
blood
want that.
pressure. They can actually cause renal failure because of the potassium
Mhm.
effects, and no added benefit. So we don't want to use ever
No.
ACEs and ARBs together. Okay. Okay, so we've talked about the single pill combinations, lots of different options there. You can use an ARB and a thiazide, but you can also use an ACE and a thiazide. You can also use an ACE and a
Mhm.
thiazide like diuretic, like chlorothalidone or something else. You can also use an ARB plus a long-acting dihydropyridine. So an ARB and amlodipine also works. Okay, so the idea is drugs from different types of classes. No, you don't want to use two drugs that affect the renin-angiotensin system, with the exception of aldosterone, which for resistant hypertension, sorry, spironolactone for resistant hypertension. But ACEs
Mhm.
and ARBs together, no. You
No.
want to use a drug that works on a different system. So you want to use something that works to open up blood vessels in the veins or venous pooling or something like that. So diuretics and calcium channel blockers have different mechanisms from
Right.
ACEs and ARBs. They have a different mechanism of action. Together, they are synergistic at
Yeah, the
lowering blood
advantage is
pressure.
that you're as far as I understand, the advantage is that you're using different mechanisms of action together all at once. You're not trying to double up on one mechanism of action because the simpler way to do that is just increase dose on the one.
Right. And you have
Okay.
better control.
Yeah.
Yeah, exactly. You're not getting any benefit and efficacy from using, yeah, the better way to do that is to optimize one dose. Exactly. Good way
Uh-huh.
to think about it. Okay, so in terms of monitoring, I think we've covered most of that. So we want to be monitoring blood pressure every 1 to 3 months, maybe even more often when a patient is first starting. Pharmacy blood pressure checks are a great high value touch point. So if somebody doesn't want to buy their own machine, like the patient who came into you and was already on the amlodipine, it's not inappropriate for you to say, let's just check it here. Ideally, they're going into your counseling room and checking it themselves. You've got a couple of devices. Remember, if you have obese patients, you have different cuff sizes. I didn't mention that
Right.
earlier, but try to make sure that you have a monitor that has different cuff sizes, because you don't want to
Yeah.
overestimate by using too tight of a cuff on somebody who is overweight and vice versa. Okay, so the most common electrolyte, we've talked about it before, that we need to monitor is potassium. We want to monitor kidney function and some other things, particularly for uh, well, I would be checking for if anybody's on a RAS inhibitor, even though those drugs are protective to the kidney, they also increase potassium and can cause some renal damage. But most of the time, especially if people have diabetes, ACE inhibitors, ARBs can be protective. We remember that from
Mhm.
school.
Yeah.
Okay. So those are most of the monitoring parameters. By the way, these guidelines don't get into pregnancy or kids. Those are different guidelines. This is for adult, non-pregnant, non-child, adult. Is
Your
that a
bread
thing?
and butter.
Yes. Yeah. Um, I feel like we've covered most of it. The only thing that I would say, and again, I don't want to go on too long for this podcast, but there's more guidelines coming out on resistant hypertension, but often those people, and I sort of alluded to this, will need three or more drugs. You can introduce drugs like spironolactone or others if people are really resistant, but typically the ACE, ARB, calcium channel blocker, diuretic, sort of something in that mix, optimized to dose, will work for most people. We don't typically recommend beta blockers anymore. We used to. We don't do that. Somebody asked me last week, what about hydralazine? That's a drug that's sometimes used actually when people come in to emerge and they need to quickly, like they have
Mhm.
hypertensive urgency and they don't want to give them an IV. They can use hydralazine because it's pretty fast acting. And you can actually use it if you want to really have something that's more titratable for somebody when you're trying to monitor them in an acute situation, but typically we're not using it all that much anymore. Renal clinics and heart failure clinics sometimes use hydralazine because it has no effect on the kidneys. So there's some niche types of drugs that we haven't really gone into too
Okay.
much, but the main workhorses we've covered.
And
Okay.
this podcast is for people who need the basics. We're looking for the basics on our way to work. So, can I just confirm with you that I understand
Yeah.
the drugs and how we're going to start them? So, we are starting all three of those at low doses at the same time, at the same visit?
No, you're going to start two. So you're going to start this.
Okay.
So let's go back to that and just kind of make sure. So we're going to do our first step is we're going to do a low dose dual, like low dose two drugs. And you can do that as one pill. You can do that as two pills. The guidelines say it's preferred to do it as one pill for all the reasons I shared with you. Like people are just more adherent, it's easier. But if people are already well managed on two pills, that's fine. The thiazide ACE combination that I told you about, irbesartan hydrochlorothiazide, because you can split that dose, is one
Mm-hmm.
that's recommended. But you're starting a low dose, two drugs. Then
Got it.
you're going to go to full dose, two drugs. So you're going
Okay.
to optimize doses of either the single pills or that one. So if you're just on irbesartan hydrochlorothiazide, you're going to start on low dose, and then you're going to go to full dose when and
Got
if
it.
you need to optimize blood pressure to get it to target. Then, if you're still not controlled, then you would start a triple. So you'd start the third complementary class. So you could actually add at that point, if a person is on an ACE or an ARP and hydrochlorothiazide, you could add amlodipine, because that's do another complementary class of drug, and that's the right amlodipine 5 or amlodipine 10 is what I would add at this point. If they're now on all three complementary classes and they are still not well controlled, and now this is for the keeners in the
Mm-hmm.
YouTube class today. We can go back and do another session on this later. Then you're calling them resistant hypertension. And by the way, we're going to have a whole other set of guidelines that come out on resistant hypertension in 2027. But usually what we start there is spironolactone. And you want to screen them for primary aldosteronism. And people can have other causes, hormonal causes of high blood pressure. And this is why we start referring to a nephrologist. This starts getting out of pharmacist territory, right? So just to give you, because you asked, that's sort of the escalation, but start with two drugs, either in one pill or two, ideally one pill if you can, and then optimize their dose until they
Okay.
get to the full dose. Okay. Instead of starting a single.
Right. So most often we're starting ACE plus hydrochlorothiazide or ARB plus hydrochlorothiazide. And
Yeah.
then we're going to full dose to optimize. And then if we have to, we're adding an amlodipine.
Yeah.
But you could do like an ACE and ARB plus amlodipine if you had like a gout patient
Hmm.
and you didn't want the
Lots
hydrochlorothiazide.
of different reasons. Yeah, absolutely.
Okay.
Yeah. That's a great reason. That's an
Okay.
absolutely great reason. The ideal is to get different complementary mechanisms of action. So yeah,
Got it. Okay.
yeah.
I had another question, but it has now escaped me. Oh well.
You can put it in the comments of your YouTube post when it goes out, and then we'll get
Perfect.
people
Yeah.
talking. I think you'll still see people, like I still have certainly seen people starting on amlodipine, but I think I'd like to see people following the guidelines and thinking about all the data that we talked about over the last hour, that most people need two drugs. And so starting them on a RAS hydrochlorothiazide type of combination is
Okay.
probably going to get
Yeah.
them to the right place faster.
Yeah. And I mean, you want, if you can do your RAS, if you can razzle dazzle right off the top, you want to because of the comorbidities and the kidney protection that
Yeah.
comes with those. Yeah, that makes
Yeah.
sense.
Um, so a couple of key things just to sum up to make sure people are listening, and I know you're listening, is so Kim, number one, how are we measuring blood pressure now?
We are measuring with a Hypertension Canada validated automatic blood pressure machine,
Love
and we are
it.
confirming at home.
We're confirming at home. One number for everybody. What's the number?
130 over 80
Yeah, and confirm at home. Out of
and
office or
confirm
out
at
of
home.
pharmacy confirmation. Very
Yeah.
good. Very good. More people will screen positive. Is that a bad thing?
Probably not.
No, your
It's
role is
probably a
more
good
important
thing.
than ever.
Yeah.
More important than ever. I think it's a good thing. I totally think it's a good thing. And lifestyle for lots of people, but most people will have to end up on medication, right?
Mm-hmm.
Okay. Um, so I think combination, I think we've taken that boat home for sure. How many, just to go back to the, I think it's good to end on how big is the problem. So what percentage of Canadians live with hypertension roughly?
20%.
Yeah, 20 to 25%, right? And then it varies based on, whether you have diabetes, et cetera. Less than 50% are treated right now. Not acceptable. Every blood pressure you check is a life that you can save. Every medication review that you do, every dosage optimization or adapt. If you're in BC, you can get remunerated for this. If you're Ontario, where I am, you can still do it within scope. You can write a pharmaceutical opinion. There are ways to build this into your workflow, people, to change people's hypertension dosages to get them to target. You have the ability to do that in most provinces as pharmacists.
I love this. We started with scaring the crap out of us, and we ended with, there's something you can do. And you know what? You have changed my mind about these guidelines, because when I first read them, starting with combination pills right out the gate kind of flies in the face of all things pharmacists, right? We were always taught you start with one agent so that you can tell what happened. You don't change two things at once. And so when I first saw these guidelines, I had a little pharmacist freak out. But you've changed my mind with the hard data.
One mind at a time.
Well, hopefully more than one mind at a time,
Yes.
because this is going public.
Yeah. One mind today, 100 tomorrow.
Welcome to the show, my one listener.
No. I'm helping you with this one. Don't worry.
Perfect. Well, thank you so much for coming on the show. And look, we crushed the timing on this.
Amazing. Just under the wire.
So these guidelines so well. I can't think of a better person to come and school me on it. So obviously I will have you back. But for now, we will say goodbye.
Bye, everybody.
Bye.
Check your blood pressure.
Check your blood pressure. Man, how great is Shelitta? What an engaging, knowledgeable, all-around lovely lady. If you want to hear more from Shelitta, you can follow her on LinkedIn and Instagram at the links in the description of this episode. She has also provided her email address if you prefer to reach out that way. Thanks again for listening. Until next time.